Good morning, everyone. Today we are going to learn about osteomyelitis of the jaw. Osteomyelitis, as you understand from the word osteo is the bone and myelitis is the infectious condition. It is the inflammatory condition of the jaw bones, which is a sequelae of the odontogenic infection. So, as we try to understand how the odontogenic infection leads to the osteomyelitic condition. When we see there is acute or the chronic periapical infection, it has various ways or various pathways of spread, that is fistula formation, cellulitis, intraoral soft tissue abscess, bacteremia, deep facial, ascending or descending infections, and osteomyelitis. Once it reaches the medullary space of the bone, it leads to osteomyelitis. So osteomyelitis, it spreads the infection from the pulp or the periodontal ligament of the tooth. It reaches the apical foramen of the tooth and then it enters into the medullary spaces. So we are going to deal it under following headings, that is definition, classification, predisposing factors, pathogenesis, clinical findings, and its management. Osteomyelitis is defined as an inflammatory condition of bone marrow with a tendency to progress. If it is confined to a limited, or if it is confined to a small area, that becomes a periapical infection. So osteomyelitis is inflammatory condition of the bone, begins as an infection of medullary cavity and Hawaiian systems and extends to involve the periosteum of the affected area. Once we see the bone architecture, we'll come to know from the medullary space, it is interconnected by the Hawaiian canals and the Ullman canals, and finally it reaches the subperiosteal regions. So the infection from the medullary cavity to the through the Hawaiian system, it reaches the subperiosteal area and then it causes a elevation of the periosteum and it causes a deprivation of the nutritional supply or the blood supply to the bone, thereby leading to the necrosis of the bone. So, the classification of osteomyelitis can be broadly classified into suppurative and the non-suppurative osteomyelitis. Suppurative osteomyelitis being classified as acute suppurative, chronic suppurative, and infantile, whereas a non-suppurative osteomyelitis could be classified as sclerosing, focal, and a diffuse sclerosing osteomyelitis, Gary's osteomyelitis, actinomycotic osteomyelitis, and osteoradionecrosis. So, why in this particular condition there is a spread of infection is because of the predisposing factors, that is a compromised host immunity or a highly virulent microorganisms which are attacking, or a jaw vascularity. If there is a compromised or a reduced jaw vascularity, then it has a tendency to undergo necrosis and there's a further spread of infection. So the conditions wherein the host resistance is compromised is diabetes, granulocytosis, leukemia, severe anemia, malnutrition, chronic alcoholism, sickle cell anemia, febrile illnesses like typhoid, and drug abuses. Conditions which alter the jaw vascularity or reduce the jaw vascularity are radiations, osteoporosis or osteopetrosis, Paget's disease, fibrous dysplasia, bone malignancies, or bone necrosis caused by heavy metals like mercury, bismuth, and arsenic. And the virulent organisms, as we know that most of these are a commensal organisms within the oral cavity, that is the Staphylococcus aureus, Epidermidis, hemolytic streptococci or Peptostreptococcus or U bacterium or Actinomyces. These tend to affect the condition. So uh, as it's been discussed, that is the infection once it reaches the marrow cavity through a trabeculae, through the Volkmann's canal and the Hawaiian canal, it reaches the subperiosteal region. So pathogenesis, the trivial trauma also could lead to ischemic changes and it causes the infiltration of the microorganisms. There is an initiation of acute inflammation which liberates the proteolytic enzymes and destruction of bacteria leads to tissue necrosis, and because of which there is a vascular thrombosis and a pus accumulation inside the intermedullary cavity takes place. Because of the pus accumulation, there is a rise in the intramedullary pressure, which causes the compression onto the medullary vasculature, which causes the vasculature collapse, and the abscess reaches the subperiosteal region, and it further reduces the vascularity. Thereby, compression on the neurovascular bundle also can happen, and there is a mandibular anesthesia seen. And once these perforate through the periosteum and they start destructing the tissues, then there is a formation of abscess or a fistula, or mucosal or cutaneous fistulae formation could be seen. And the bone which lost its blood supply becomes dead, or it is also called as a sequestrum, which has a woody appearance. And in response to this necrotic bone, the body tries to contain the infection in its place and tries a regenerative process, which involves the formation of involucrum. So, coming to the osteomyelitis, the clinical features can differ in the acute and chronic cases. In case of acute suppurative osteomyelitis, there is a deep, intense pain with a high intermittent fever, paresthesia and anesthesia of the mental nerve, firm cellulitis of the cheek, and regional lymphadenopathy. Along with that, the patient appears to be chronically dehydrated, and when we examine intraorally, we can clearly see a etiological factor like the infected tooth or the patient who is immunocompromised. When we see clinically, you can see there is a pus discharge, and when the bone is seen, it is clearly unhealthy and it has lost its vascular supply. Whereas in the chronic suppurative cases, the mucosal and cutaneous fistulae are seen, exudation of a pus is present, induration of the soft tissue, wooden character of the bone. That means the bone appears as if it is looking like wood. That is, it has lost its blood supply. Okay, it's lost its texture because of the lost vascularity, and there is a pain and tenderness on palpation. Formation of a sequestra is seen, which is very much evident intraorally. And when we further investigate through the radiographs, we see there is a moth-eaten appearance of the region, along with there is a loss of trabecular pattern, and sometimes we can even see there is a pathological fracture. So the further investigations which need to be done are the culture and sensitivity to identify the causative microorganisms, and the imaging required is a plain radiograph or a conventional radiograph along with the CT scan or the bone scintigraphy. Radiographic appearance, there is a scattered area of bone densification, moth-eaten appearance, radio-opaque islands, which are nothing but the sequestra, which are more dense, which appear more dense than the involucra, and a stippled or a granular densification is seen. We can see the moth-eaten appearance along with a change in the trabecular pattern, and there is small areas of densifications are seen. Even in the CT scan, also it is evident. When we perform the bone scintigraphy, that is a radionucleotide scanning, the technetium 99 is injected, and we get an entire skeletal image wherein there is a increased blood supply and a reactive bone formation due into the chronic osteomyelitis cases. We see a enhanced appearance on the PET CT. Coming to the treatment part, it is first we need to hospitalize the patient, and to start with empirical antibiotics, identify and correct the host compromised condition. For instance, if the patient is having uncontrolled diabetes, or a patient whose organ transplant recipient who will be immunosuppressed, or that has to be identified and it has to be corrected. Extraction of the teeth, incision and drainage. Sequestrectomy is nothing but removing the dead portion of the bone, that is the sequestrum, is called a sequestrectomy. Sequestrectomy and saucerization, decortication, closed wound irrigation and suction, and resection and reconstruction are few of the options. Coming to the treatment of osteomyelitis, first to start with the empirical line of treatment, that is the penicillin and its derivatives are best suited, and clindamycin if they are allergic to penicillin, and vancomycin if there is a resistant Staphylococcus epidermidis or methicillin resistance Staphylococcus aureus is present in the site. A combination of vancomycin with rifampicin if the prosthetic joints are present or if there is life-threatening condition is seen. Acute infections or treatment for the acute osteomyelitis should ideally last for 4 to 6 weeks duration, whereas the chronic infection or the chronic osteomyelitis requires a treatment of at least 3 months duration. Coming to the surgical line of treatment, that is a removal of a sequestrum or the dead bone, it's called a sequestrectomy. Sequestra is mainly a cortical bone, but it can also be corticocancellous. The sequestrum is avascular, therefore it is poorly penetrated by antibiotics, so it has to be taken out so that the antibiotics are reaching the area through the normal vasculature and the normal reparative procedure starts. This method prevents the spread of infection and minimizes the tooth and the bone loss. If the infection is more pronounced, then the sequestrectomy along with saucerization, that is, along with the sequestral removal, unroofing of the bone to expose the medullary cavity for the thorough debridement should be done so that there is no residual infection left. Margins of the bone overlying the focus of the osteomyelitis are excised, allowing the visualization of a sequestra and the excision of the affected bone. Decortication refers to the removal of a chronically infected cortex of the bone. Lateral and the inferior cortex are removed 1 to 2 centimeters beyond the affected area. This option or this surgical option is chosen only when the conservative methods have failed. Next is closed wound irrigation and suction. The tubes are placed against the bone to allow the drainage of a pus and serum and to provide room for the irrigation, thus reducing the number of remaining microorganisms within the site. And another tube is placed like a nasogastric tube or the French catheters, so that the irrigating solution like saline and the antibiotics such as clindamycin or the neosporins could be injected locally after flushing out all the infectious material. So this aids in draining the remnants of the uh, draining the remnants of the purulent material from the surgical site. Resection and reconstruction is required if at all there is a pathological fracture or persistent infection after decortication is still there. It is necessary to resolve a low-grade persistent chronic osteomyelitis. So we have got to resect the osteomyelitic part of the jaw along with a normal bone of 1 to 2 centimeters margin. So this kind of a resection is generally required in a chronically infected cases and which have got a very poor prognosis with a conservative management. So in these cases, a resection has to be done, followed by that the reconstruction, either a primary or a secondary reconstruction has to be considered. So this is one such case wherein we can see the mandible, the hemimandible is involved along with the involvement of the overlying skin. So a complete segmental resection is done, and to maintain the form of the mandible, a reconstruction plate is placed in the beginning, and following the healing after a 3 to 4 months duration, a secondary reconstruction can be considered. Another deadly consequence of the osteomyelitis in case of a post-irradiation patients, that is the patients with a oral cancer and who would have undergone a radiation therapy, there is one condition which is called as osteoradionecrosis, which can happen because of a chronic non-healing wound which is caused by three H's, that is hypoxia, hypocellularity and hypovascularity. So irradiations more than 5,000 rats when are given to the oral structures and the bone is there intervening, then it causes the death of the bone cells, obliterates the arteries, and it causes end arteritis, thereby leading to hypoxia and hypercellularity and um, hypoxia, hypercellularity, and the hypovascularity. Thereby, it leads to a tissue breakdown and there is a non healing wound present there. So clinically, when they present, it will be like a pain in the region of exposed bone, trismus, fetid odor, and there could be a pyrexia, intraoral or extraoral draining sinus and fistulae, pathological fracture, discomfort because of the abrasion of the exposed bone, induration and ulcerations are seen. We can see over here the necrotic part of the bone is completely exposed intraorally as well as extraorally. And when we see radiographic evidence, when we see that radiograph, there is a fracture of the body of the right mandible and which is displaced. This is a pathological fracture. Because of the osteomyelitis, the bone is weakened and there is a fracture. So such kind of post-irradiation cases have a very poor prognosis because of the hypocellularity and hypovascularity. So these cases will not respond to the conservative management and we have to go for a more ablative surgeries wherein we have got to resect the necrotic bone completely and then reconstruct them secondarily with a free fibula graft which carries its own blood supply. So the free fibula flap is the one wherein a bone from the fibula is taken along with its nutrient artery and the vein, and these are connected to the recipient bed, that is generally a facial vein or a facial artery and lingual vein or artery. Coming to the osteomyelitis, the overall view or the overall treatment plan is first of all we need to control the infection. We got to hospitalize the patient and correct their dehydrated condition. Gentle irrigation of the soft tissues, anaerobic and aerobic cultures to be taken for the specific antibiotic therapy to be initiated, supportive treatment and debridement of the bone, initiation of the bleeding points, analgesics or narcotic analgesics, and HBO therapy. How the HBO therapy helps is hyperbaric oxygen therapy increases the arterial and venous tension of the oxygen, which supplies additional oxygen to the through the plasma to the tissues. It has got four prominent effects. One is first being the direct bacteriostatic effect on the microorganisms. So it reduces the bacterial count in the area. It increases the leukocytic bactericidal activity. It activates the leukocytes and enhances its bactericidal activity and fibroblastic activity, which helps in reparative process as well as proliferation of the granulation tissue. So both of this fibroblastic activity and the granulation tissue, both of this help in repair of the tissue. So the hyperbaric oxygen is given in a closed chamber. It is, as the name suggests, hyperbaric means it is given at a higher pressure, that is about 2.4 atmospheric pressure. 100% oxygen is delivered to the tissues at 2.4 atmospheric pressure for a minimum of 30 minutes. That is a standard unit of a HBO therapy, that is dive. One dive is equal to exposing the patient to 90 minutes of exposure to hyperbaric oxygen therapy. So, in these patients who are having the chronic osteomyelitis or who are having the osteoradionecrosis, we have got to give at least 5 days a week. HBO therapy has to be given one dive at a time. Uh, Osteomyelitis management as being dictated by the Mark's protocol in case of a long-standing or a chronic osteomyelitic cases and osteoradionecrosis, we have got to stage them into stage 1, 2, and 3. Stage 1 being a 30 dives of HBO given to prior any surgical intervention and observe the patient. If the patient shows any improvement or a response of the tissue is there and it is healing without any surgery, then you're going to just observe the case. Okay. If there is no response, if there is no response, then it goes to stage 2, wherein already 30 types of HBO has been given, and here we have got to go for a surgical resection, peripheral resection, or the sequestrectomy or the cortical plate removal, that is a decortication, has to be done, and followed by which the 10 dives or the 10 dives of HBO therapy has to be given and observed. If there is a resolution, they are the stage 2 responders, and if there is no resolution, then they go to stage 3. That is, the previous 30 dives have been given prior to any surgical intervention, and followed by that, surgical resection has been done and 10 dives have been given. The soft tissue loss necessary reconstruction, the myocutaneous flap or the vascular transfer has to be done, and the bone resection at 3 months minimum. Commonly transfer the resection has to be done, and 10 dives of HBO therapy should be given following a resection in these cases. So, osteomyelitis. So, to summarize, first we need to understand what is the cause which has led to the progress and necrosis of the bone. So, eliminate that cause, that is to improve the host immune response. One, and second thing is remove the causative factor and improve the patient's nutritional condition. Along with that, if required, even the surgical intervention has to be done so as to control the interaction.